right, hello everyone. I want to thank you for joining us on today's webinar discussing hypomania is not a little mania nor treated like one. And I want to let everyone know that there will be a 15-minute question and answer session at the end of this chat, and you can ask your questions by typing them into the Q&A box on the bottom of your screen. And I'm proud to introduce Dr. James Phelps with us. He'll be joining us today. He has over 20 years of practice in treating complex mood disorders, and he is the author of several books, including Why Am I Still Depressed? And An Approach to the Mood Disorder Spectrum. And he is also currently starting depressioneducation.org to provide everyone with free resources. And with that, I'm proud to introduce Dr. James Phelps.
Thank you very much, Jake. And thank you to the International Bipolar Foundation for the opportunity to talk with everyone today. And thank you for all the attendees to show up at this time. I appreciate the opportunity to share some ideas that I've been harboring for a long time, as you will surely gather. The most important of which I think is this one. Hypomania is not a little mania. It's really, I think, qualitatively different, even though it blends in with full mania. And actually, two-thirds of people living with bipolar don't have mania. They have hypomania or some variant thereof. So even though bipolar disorder is defined by manic symptoms, two-thirds of the people, like 2 to 1, do not have manic symptoms. They have hypomanic symptoms at most. So a very, very important topic. We're talking about two-thirds of the people living with bipolar disorders. So that's the arena, and I invited Mr. Volo to ask me some questions. I submitted the questions in advance, I'll admit that, just to structure us a little bit. So Jake, you want to take us away?
Yeah, so let's start by getting clear just exactly what is hypomania.
Well, I could answer it in a kind of a controversial or provocative way by saying, what is hypomania? It's depression. Well, it's depression with these manic symptoms, either mixed in or at separate phases in time. But the dominant symptom for people living with bipolar without mania, namely living with hypomania and its many variants, the dominant symptom is depression. So really, we're talking about depression plus some other stuff. And that other stuff is what we're going to be talking about, and we'll look in detail about like what exactly symptoms are we talking about. But I want to emphasize that it's depression plus some other symptoms. And then I'm realizing, of course, that people who are attending, they know this very likely from deep experience. I know it from talking with people like you over now almost 30 years, and listening to the stories of the experience of these variations of bipolar disorder. So the dominant experience then is depression plus some other symptoms. I thought I'd just give you an example that I put up on my old website many years ago of hypomanic symptoms. So I'm just going to read you a very brief paragraph. This is a woman who wrote this on a blog post. She said, when she is in the hypomanic phase, she says, I have a very loving feeling toward the people I care about, an uncommon ability to get things done, an expanded ability to multitask, an organizational acuity that is second to none, and a willingness to engage with people. I just desire to spend more time with people I care about, and even those I don't. I'll read you another passage from hers, but so that's a nice description of something. And you can see that this is a far cry from full manic symptoms that can be really quite dangerous at times, through ability to destroy one's finances and relationships and jobs. This is very different than that. So we'll look at some variations on that in a moment. In fact, I think, Jake, that's where we could go next.
Yeah, so how do the symptoms of hypomania vary from just barely bipolar 2 to almost bipolar 1?
And to answer that, I asked Jake to put up a figure of mine that I use in talks and put in my book a while ago. Um, what I think of it as the rainbow wedge. So if you think of mood disorders as a spectrum from pure or plain depression to fully manic depressive illness, on that spectrum, there are people all the way along in between. That used to be controversial because in fact, the DSM, the official rule book on how to make psychiatric diagnoses, doesn't doesn't talk about mood as a spectrum like this. But if you look at what researchers have been doing in the last 10 years, like since the last DSM edition came out, um, and the way bipolar experts around the world, including people with lived experience, talk about their experiences with bipolar disorder, it's very clear. No one really quibbles with the idea of a mood spectrum anymore. And what defines the spectrum is this wedge of hypomania from zero at the plain or pure depression end, that's kind of defined by not having those hypomanic symptoms, then gradually increasing all the way across to when those manic symptoms become fully expressed in manic depressive illness at the other end of the spectrum. So what I'd like to do then is to kind of drill down, Jacob, show our next slide, is drill down into that wedge to look at, well, what exactly do these symptoms look like at these different places along the wedge? And so next slide. So this table is a little busy, but you'll figure it out very quickly. Imagine if we drill down at D, the full manic side. We're looking at these various symptoms of mania as defined by the DSM. So over on your far left, you see distractibility, sleep and grandiosity, and so forth. So those are the official symptoms of mania. Look at how they express over here on the right side of the figure at D, fully manic, when people are so distractible, you can't even engage in a conversation with them. They're not sleeping at all. They're dangerously overconfident and making impulsive, imprudent judgments. Their ideas are so wild you can't understand them, and so forth. So that's column D. But if we move over to column C, where this would be the official DSM definition of hypomania, the one that, when found with depression, is sufficient to arrive at a diagnosis of bipolar II, then you can see the symptoms, the very same symptoms, are different. So in terms of distractibility, it's just difficulty focusing one's attention. This is like having attention deficit disorder, but now not constantly, but rather episodically, as we would expect with hypomanic episodes. Sleep could be down to just a few hours, and meanwhile, people are highly productive. Oftentimes, what are the men doing? They're playing sports, including playing sports online. What are the women doing? Pardon the characterization, and this is a gross overgeneralization, but there's some truth in it, as explained to me by one of my female patients. They're cleaning the house, going from one room to the next, cleaning, not finishing that one, moving on to another one. So there is a little bit of a gender difference in terms of how this might express itself, I think, this overactivity. And now one more important point about column C, grandiosity, which is a symptom of manic. When it's fully manic, people have grandiose delusions, for example. But in column C, grandiosity just becomes kind of pronounced to the point of being maybe just a little narcissistic, a little over confident in oneself, so that diagnostically, sometimes one of the ways to detect, is this really hypomania, would be to find people who don't really like going to parties at all in the first place. But if they do go, they kind of like hide over in a corner unless they're in a hypomanic phase, in which case they're out there in the middle and they are doing the literally life of the party routine, talking to people whom they don't know and have lots to say and lots of ideas. It's just, it's not even really narcissistic. It's just a full of self-confidence. It's a confidence variable more than a grandiosity variable, if you will, and so on. Now, let's shift over to column B, where things start to get even more subtle. So distractibility is just some difficulty concentrating, but not really enough to impair necessarily with function. Sleep is some more insomnia than usual, but not just going with a few hours. The overconfidence part, the confidence is just being really brilliant and having great ideas, very sharp thinking, quick thinking. Likewise in terms of idea generation. And then activity, maybe it's a little accelerated, possibly not even to the point where even a good friend or significant other would necessarily notice it as like different. and so forth. So that's column B. And then column A, the problem becomes even more pronounced in terms of like, is this really hypomania? This is just like um, for most people, it's like the woman whose example I described. It's just like having a really good day. This is not pathology at all. And if people didn't have depressions, big depressions, to go with this, then we wouldn't even, there would be no point in seeing a psychiatrist, that's for sure. There would be no point in invoking any kind of diagnosis because it's just having a really good day. And some people get to live in column A, and a few people get to just live full time in column B. That's called hyperthymia. It's not cycling, it's just the way they are. Um, if they get that and no depressive episodes, that's like winning the lottery. You got a lot of the fun stuff um, and none of the downside that goes with the full bipolar, both ends of the spectrum experience. So I hope that that table helps in terms of understanding, well, what is hypomania? It's this whole range. Remember, these are just drill cores into a continuum. There's people all the way along in between with different variations in between those samples. Thank you, Jake.
Great.
Where
So
would you
we'll
say,
go forward
where
with
would
our
you,
next question, which is what does this mean practically speaking? Why does this wedge thing matter for clinicians, therapists, nurse practitioners, psychiatrists, and patients and families?
right, good, thanks. So what matters is that this determines treatment. Hypomania is treated in a fundamentally different way than manic and depressive episodes, or for the few people who have it, just manic episodes. And what's the difference? The focus for mania is on preventing the next episode. The focus for hypomania is to stop the cycling. And why stopping the cycling? Because I'm having the afterthought, well, so for bipolar 1, for mania, you also want to stop the cycling, but the focus oftentimes is driven by the manic episode, whereas in hypomania, bipolar 2, and the more subtle versions of bipolar experience, the focus is on stopping the cycling. Why? Because the cycling leads to depressive episodes. Hypomania unto itself is not really a treatment target. It's not necessarily a bad experience, except when it trends into its negative phases, which we'll look at in a minute. The problem is that it predicts depressive episodes. People who have had both hypomanic phases and depressive episodes would understandably want to get rid of the depressive episodes, but not necessarily the hypomanic ones. The problem with that strategy then is that unfortunately, cycling is the problem. Having hypomanic phases doesn't always, but almost always leads to either directly following or later a depressive episode. So the way to stop the depressive episodes is to stop the hypomanic episodes. Now, that doesn't mean living in a straitjacket and not having any fun. It means getting to live where most people live. It's the mood position in the middle, not up, not going down, just not going into those really accelerated, over accelerated phases. It's too much energy um, of hypomania. So the big difference then in terms of treatment is the focus on stopping the cycling. We're not worried about preventing mania. And since, and I'm going to shift gears for a second, this is the second half of my answer to that question, Jake. Since we don't have to worry about preventing or treating mania, we don't have to use the fully anti-manic strength medications. We can use medications that are anti-cycling, but because the dominant experience in people living with hypomania and more subtle variations, the dominant experience is depression. We're going after the cycling with tools that have an antidepressant effect. Because most of the time when people show up with like bipolar 2, they're not showing up because they're hypomanic, they're showing up because they're depressed. And so the target at that point is treat the depression, but do it in such a way that we also at the same time are trying to suppress the thing that drives cycling. So our treatment of bipolar 2 and more subtle variations of bipolarity is to stop the cycling with things that have antidepressant clout, unlike bipolar 1, where we're treating with things that have anti-manic treatment or preventive capacity. So obviously I'm talking about like full dose lithium and the various antipsychotics that are used as anti-manic agents. We don't need that in bipolar 2. We don't need that for hypomania. We can use mood stabilizers with antidepressant effects. I actually think that we should coin a new term for the jargon if we didn't have enough. Um, that would be MSAEs, not like SRIs and SNRIs. I want to coin the term MSAEs, mood stabilizers with antidepressant effects, because those are the go-to tools for treatment of hypomania, namely treatment of the depression and the cycling that goes with episodes of hypomania. So that's the long answer to the question of how does treatment differ between hypomania and mania?
Well, thank you for that. So we'll move forward to our next question, which in terms of treatment, what are the usual approaches for hypomania?
And for our audience today, just in case you're pacing yourselves, we're going to take this question, and then I asked Jake to deliver me another one, and then we'll be maybe moving on early. We'll see how we're doing to some questions from you all. So question then is, what are the usual approaches for the treatment of hypomania? Now, you can think of this as like it comes in two pieces. There is a non-medication piece and a medication piece. A few people can do this with the non-medication piece alone. Most people, in my experience, need both together, but not just medications. There's the non-medication approach that is pretty much universal in terms of like this could be useful for nearly everyone with mood and energy cycling. Again, the target for hypomania, meaning like bipolar 2 and more subtle variations of bipolarity, the target is cycling. So what are our anti-cycling agents that have antidepressant effects? Starting with the non-medication approach, this is becoming a very large component of treatment for bipolar disorders, all variations of bipolar disorder, because it's increasingly recognized that circadian rhythm, our body's natural internal clock, is part of the whatever it is that's different about people with bipolar. Um, not everyone, but for many, in fact, probably the majority, in fact, maybe most, it's there's something different about your clock. There's something about your clock's ability to, it's like being able to go off the clock and being able to be active when the clock would be otherwise telling people to be asleep. Or unfortunately, sometimes saying you should be asleep when you really need to be up and doing things. So, kind of a wonky clock or an ability to get off the clock is a core ingredient in probably most people's whatever it is that's different about people with enough bipolarity to come to attention and warrant like diagnoses and treatment. So, because it's a clock-based thing, a phenomenon, this lived experience of bipolarity, um, that means that doing things to kind of strengthen the power of your internal clock to drive your sleep-wake cycle, that's a treatment. And now, probably most of you who are attending this talk have already figured this out from experience. You've heard this notion before. So I'm preaching to the choir here, I imagine. I just wanted, you can see I'm very excited about this. There's a whole division of the International Society for Bipolar Disorders, the chronotherapy task force, that's working on the physiology of this and then turning that understanding of what is it that how does this play into bipolarity into treatments? And what's the core method that goes with this focus on the internal clock? The core method is social rhythm therapy, social rhythm therapy, or SRT. Now, there's a whole process to social rhythm therapy. And one of my colleagues and teammates on our film that we're making, the documentary that we're going to make about the bipolar spectrum. It's about halfway completed now. One of my colleagues on that is Dr. Holly Swartz, who has written now a workbook for social rhythm therapy, the social rhythm therapy workbook. just came out a few months ago, like 2 months ago. So that's great because getting SRT, finding a therapist who can deliver SRT for you and help you work through the methods is really hard. There just aren't very many SRT therapists out there. So you can access the whole SRT therapy in Holly Swartz's book, the Social Rhythm Therapy Workbook, um, and you'll see the whole picture. I'm going to narrow that down to the one ingredient in that set of tools in social rhythm therapy to the one ingredient that I think physiologically and by my experience is the most important. In other words, this would be like your starting place for sure. You can broaden it out and use the other tools as well, but you really want to have this one. And that is, well, let's see, think about it. What is the most powerful driver of circadian rhythm? What is the most powerful ingredient in your experience that sets your biological clock? And you will know from if you've traveled across time zones that you can move your clock around. And the thing that drives it most strongly is your sleep cycle, when you fall asleep and when you wake up. Now, you can't control those things directly. You can't make yourself fall asleep. So, what you can control is when you get in bed and when you get out of the bed. So these two ingredients, I think, are the most central, the most important in all of social rhythm therapy. And I know that Dr. Schwartz agrees. Um, so that if you were to do nothing else, you would definitely want to do these things to have a regular bedtime and a regular rise time. That sort of sounds easy, but for so many people, that is extremely difficult. And so, Jake, I think this is where I invited you to show a page from my website. If you can load that page. Right, that one. So this is my new website. I had an old one that just got so big you could hardly make your way around it. So I started a new one, depressioneducation.org. And this is an attempt to kind of shrink it down to just to the essentials. Thank you very much. And recognition that, you young people like Jake Volo, they don't read books that much anymore. And maybe you don't even read whole thick websites. It's got to be a short website. One of my colleagues said, "Oh yeah, there's the acronym is TLDR, too long, didn't read." It's like, oh yeah, I've been guilty of that one for sure. So this is the anti-TLDR version of my website, depressioneducation.org. On that, there is this page about making sleep regular, in recognition for how difficult this can be for some people to get from erratic sleep to regularized sleep. I said, okay, here, let me offer you some suggestions. And Jake, if you'll scroll down for a second. I went so far as to turn this into a video because I'm aware that some of the youngest people don't read websites anymore. They want to see the video version. So there's a video version of this as well, talking about all the ingredients in making your sleep regular, starting from, as I think probably some people who are attending today, if not now, then at one time in your life, you were up until 1, 2, 3 in the morning and getting up really quite late in the morning because you'll have lots of reasons to not want to get in bed and lie there awake. In part, it's a time to have all those awful thoughts of depression or trauma recall. And so oftentimes people stay up late and distract themselves with television in particular, or now the modern versions thereof. So staying up late is easy. And for people with bipolarity, staying up late is particularly easy. It's the nature of bipolar clocks to drift later and later to allow you to stay up later and later, so-called evening chronotype. So it's very difficult then to ratchet that back in the direction of something a little bit more like 10:30 as a bedtime, as a getting in bedtime, and then a regular rise time, 7.5 to 8 hours thereafter. So 6:30, 7 in the morning. So that web page can show you all the details about tools and tricks using shifts and light and exposure to darkness and deliberate darkness and virtual darkness using amber lenses and using a dawn simulator in the morning to provide a dawn signal, even when you've blacked out your bedroom, which you need to do. All that stuff is on the website and described in that video. And I'd be happy to go into some more detail about that if you wish in our question and answer time, because I think it's so important. So remember, what I'm talking about now is this is the non-manic treatment of hypomania or bipolar II and its more subtle variations. The non-medication treatment, the anti-cycling treatment, is social rhythm therapy, particularly a focus on sleep rhythm. And then finally, to come around to the medication approaches, there's one obvious medication candidate. I think most people now agree on this. Most of the guidelines agree on this, and that's lamotrigine. Why lamotrigine? Because it has no significant long-term risks that we know of, even though we've been using this for over 30 years. There are very few medications in psychiatry about which we can say that. First of all, we don't have that many years of experience, like 30 years, for most of the medications that we use, particularly the newest ones. And we have almost no medications that have zero significant long-term risks. So since mood disorders of this type tend to be long-term problems, it's likely that you need a long-term solution, not necessarily lifelong, but long enough to get a really good grip on your symptoms so that they're really no longer dominating your life. And then you could talk with your providers about what are the pros and cons and risks and benefits of trying a period of tapering off something like lamotrigine. That's a very controversial territory. I'm of the belief that everyone deserves a try at that when they choose to do it under well-protected circumstances when there's a good safety net and so on. So not necessarily lifelong, but definitely we're talking about months to years. And so we need a treatment that is not accruing risk for you over time, and that puts lamotrigine right up at the top of the list. There's some controversy about how fully effective it is, but in my view, that just almost doesn't matter because it's tolerability in the jargon. It's the fact that for most people taking it, they have no side effects and accruing no significant long-term risks. That trumps effectiveness as long as it works, and we can find that out, and it takes a 2-month period of time to figure that out. So lamotrigine, obviously my favorite thing because I'm so worried about doing harm with the treatments while we're trying to do good.
Mhm.
And then secondly, so Jake, how are we doing on time here?
Yeah, we're doing great on time.
Okay, good. Um, I'd like to introduce you to a new medication, one of which you may not have heard. It's called lithium. Well, low-dose lithium. Low-dose lithium is like a different medication compared to full-dose lithium. Full-dose lithium has risks to kidneys, has to be managed carefully, blood tests to check and make sure your kidneys are still doing okay. Full-dose lithium has potential risk to your thyroid function. It can interfere with your thyroid function and requiring perhaps that you have to take thyroid hormone to make up for what your thyroid gland can no longer put in your bloodstream. Full dose lithium carries those two risks for sure. And if the dose gets too high, as I think everyone knows, you can get some really awful symptoms of lithium toxicity. So dangerous when the dose gets too high, and it can get kicked up there by non-steroidal anti-inflammatories like naproxen and Motrin. So you have to be really careful with full dose lithium. Low dose lithium is like a different medication. Low-dose lithium, according to nearly everyone, does not carry risk to your kidneys. No significant risk to kidneys at low-dose lithium. Well, what is low-dose lithium? I kind of think of it as the dose of lithium that you need to treat or prevent mania. It's everything less than that. So the dose that you need to treat mania, we do this by blood levels of lithium, and the units don't matter, but the numbers are like 0.6 to 1.1 or 1.2. 0.6 to 1.2. That's the doses one uses to treat mania or to prevent mania, more in the like 0.6 to 0.8 range. And a few people would say 0.5 is enough for that. So 0.5 and less is low-dose lithium. Well, this just doesn't get much study because the, the version of bipolarity, the version of bipolar disorders as defined by diagnoses that's been studied for years is bipolar 1. And for that, you need zero point 0.6, some people would say 0.5, 0.6 to 0.8 for prevention, and 0.9, 1.0, 1.1 for treatment of a manic episode. So almost all of our research has gone into those higher blood levels, full dose lithium. We have very little research by comparison on low dose lithium. Well, in part because, well, what do you use low dose lithium for? There are two main things one might use that for. One is as an add-on to an antidepressant in plain old, pure plain depression, not bipolar. Lithium can still be used in pure or plain depression, what might be called unipolar depression, as an add-on to an antidepressant. And there's a significant research literature about that. It's been around for years. In fact, it's been around for so long that most of that research was done adding lithium to a tricyclic antidepressant. There's actually only one, or maybe there's another one or two studies on adding lithium to a SRI, one of the more modern antidepressants. Point being, lithium has been used in very low doses in that fashion for a long time, very well understood. And when doing that, one does not need to worry about lithium toxicity. It appears that you don't really need to worry about, although it's worth tracking your kidney function just to make sure that everything is okay. But lithium at those low doses appears not to adversely affect renal kidney function. Um, I just published a paper with one of my colleagues on what happens to a thyroid with low dose lithium. And the answer is not as much shift as you see with full dose lithium, but still some shift in thyroid function such that, yeah, you need a blood test before you start and another couple of blood tests afterwards to show that your thyroid is still doing okay. If you had a really great result from adding low dose lithium and your thyroid was drifting in the direction of, oh, my measure is going up, which means my thyroid function is going down. Sorry for the backwards. It's just the way we measure that thing called TSH. Um, if you were getting that and you were like way better, you could think about, well, you don't have to go off low dose lithium. You could add some thyroid hormone and make up what lithium is interfering with. Point being, low dose lithium either won't affect your thyroid function, or if it did and you were getting a great response to lithium, you can easily fix the problem. So low dose lithium in my head is a low risk, very unlikely to cause side effects treatment option. And that, remember, that's sort of where this was all going. You don't need the anti-manic effects. You don't need the atypical antipsychotics. You don't need full dose lithium. You need anticycling clout with no long-term risks and no side effects is what we're shooting for. Lamotrigine gets us there, and low-dose lithium, I think, gets very close, much closer than the other treatment options for bipolar disorders generally. I think that's everything I was going to try to say about that for now. Oh yeah, so I said there are two reasons to look at low-dose lithium. One is augmenting an antidepressant in unipolar depression, and the other is you just need more anticycling clout, and you need it from something that has some antidepressant clout as well, a mood stabilizer with antidepressant effects. Low-dose lithium is that. Very, very little research on lithium used in that way. In fact, I'm not sure if there is any. Oh yeah, there is one study. There is one study out of Harvard, and it was negative. It said, no, that didn't work, which was very, very daunting, but not daunting enough to make me stop talking like this because it was one study and there were some reasons to think, you know, a brief anecdote about evidence-based medicine. In the residency programs, for example, the joke about evidence-based medicine is if the study agrees with your position, then you cite it. If the study disagrees with your position, then you quibble with the design. Oh, they didn't do this, they didn't do that, they should have done. So I was about to do some quibbling there. That's not fair. Suffice to say, this is not a really solidly evidence-based approach. It's something that I've evolved over many years, again, trying to avoid those long-term risks and side effects. Because last thought about low-dose lithium, in my hands, this is using a 150 milligram capsule, the smallest one they make, and we're adding it to something like lamotrigine and adding 150 milligrams. That shouldn't be enough to do anything in most bipolar researchers' minds. And yet there's a whole other story about lithium and anti-suicide effect and lithium in the water supply in places around the world where it appears to have lowered suicide rates, and a whole other story about lithium and the possible prevention of dementia, which I think is really quite possible. And that's why I take low-dose lithium, for the prevention of dementia. And we have another study about to come out that will, I think, really define whether or not that's a good idea. Um, After having one earlier randomized trial that shows that, yeah, that's a pretty good idea. So very, very low dose lithium, like 150 milligram capsule. I start when I'm doing low dose lithium, start with that. And if it causes no problems, but no benefit either, then go to two of them, 300 milligrams nightly. And if that causes no problems at all, but no benefit, then three, we go to 450. And I would carry that on, same logic, until we got to 600. And then let's check a blood level, just make sure that we're nowhere near going beyond zero 0.6, where we started moving into a different risk territory. So that's low dose lithium in my mind, stepping your way up. And did you hear all the way along, the criterion is no side effects. If you get one, we'll turn the dose back down and let's watch a little bit longer before we arrive at a conclusion as to whether this is helping or not. Meaning that this treatment involves no side effects and close to no long-term risks. That was the goal. That and lamotrigine, I think, are the top candidates, in my view. A review in JAMA, the Journal of the American Medical Association, by Andy Nierenberg and his team from Harvard, put lamotrigine, I think, way up on the list of main options. They didn't talk about low-dose lithium in this fashion. Um, but I was glad to see that that's how they framed it in an international publication, not for psychiatry, but for all of medicine. There, okay. And Jake, I think we have one question left.
Yeah, so we have one more question before we'll dive into the audience question and answer. So if you have questions, please start to consider what they are and even type them in the box. And so moving forward, I understand that hypomania is not always a positive thing. Just like there's dysphoric mania, can there be dysphoric hypomania?
Again, my planted question. Thank you, Jake. Yes, there can indeed be dysphoric mania and dysphoric hypomania. Let me just give you an example. That same woman from whose blog post we heard earlier writes of her later experience of the same hypomanic episode. She says, "While I still have a lot of energy, I don't have that love the world feeling. Things just don't slide off my back. I become far less happy, joyful, and kind. I dislike being criticized in any way." And then the little example that I think just shows what we're talking about. She says, "If I've been playing my auto harp at my mother's assisted living facility and jumping up and down to help all the participants turn the pages, I suddenly feel like the staff should be more helpful in doing this." Just, it's so subtle, and yet it's such a clear shift for her that she would put it into her description of a hypomanic episode. So it is possible for manic symptoms, including the negative ones, irritability, agitation, anxiety, and mind racing so fast that attention becomes difficult. It's possible for those manic symptoms, the negative ones, to get mixed in with depression. And old manic depressive illness, that's bipolar 1. So you can have those negative symptoms, that would be a dysphoric mania, having negative symptoms mixed in with depression, negative hyperenergy symptoms mixed in with mania. And likewise with hypomania. And again, those four, and I'll tell you in a minute why I emphasize those four: agitation, too much energy, just like too much energy inside your skin; irritability, anger; um, Anxiety, just everything is full of what if this and what if that, worry, and attention problems. Things are going so fast. Someone said it's like watching 6 television stations at once. It's just too much is going on. And so attention is difficult. Anxiety, anger, agitation, and attention problems, the 4 A's, as has been described by one of the bipolar researchers, Roger McIntyre. Those are the negative symptoms of mania that can be mixed with depression, or most commonly mixed with depression, in what we now call a mixed state. Um, when I say we now call, because the DSM changed the rules in 2013 and admitted that mixed states are not full manic symptoms and depression symptoms, but can be a subset of manic symptoms plus depressive symptoms. And that subset, the most common in that subset, are the 4 A's: anxiety, anger, agitation, and attention problems. And those can then be mixed in with a hypomanic episode, like playing your auto harp at the assisted living facility, and then the staff should be turning those pages. It just starts to shift into this kind of irritable, agitated experience, not this joyful, positive one that she had described earlier. So yes, it's possible to have a dysphoric hypomania. And how do we treat that? Um, excuse me, my dog has decided it's time to. Hey, Lucy, she'll stop in a minute. Um, so how do we treat that agitated dysphoria as part of a hypomania experience? Um, Again, remember, it's anti-cycling is the goal. In this case, we'd want perhaps something that's got a little bit more clout against anxiety, agitation, irritability, and attention problems. We might think about something that's a little bit more powerfully anti-manic. Um, but I have confidence that if we can just stop the cycling, this symptom will stop. And I might just stick with stopping the cycling. And last thought, I would immediately turn my attention to, is there an antidepressant on board? Because antidepressant can induce mixed states. So the simple solution and the absolute must starting place for a dysphoric or mixed state of any kind is to look to see if there's an antidepressant around and gradually taper that out of the picture, because that could be where the problem is coming from. And since they drive cycling as well, maybe we don't need any other anti-cycling ingredients. Maybe we just need to gradually take that antidepressant out. Excuse me. Look, you ought to go. I think so. Off you go. All right. So I think Lucy was getting a little tired of me talking like this. I think we must be ready to move on to some questions from you all.
Yeah, so we'll go into the question answer now. So the first question has to do with the columns shown from earlier. So I'm going to pull them up, and they are wondering if cyclothymia could be considered more column A or column B. Give me 1 second to pull this up.
Yeah, I appreciate that question. Yeah, good. Um, by definition, as our questionnaire likely knows, cyclothymia is hypomania and not severe episodes of depression, but mild episodes of depression. So it's cycling, but not as pronounced as a full manic episode and a full depressive episode. It's hypomania, kind of by definition, and mild depressive episodes. Well, this cyclothymia is just a name for a variation on the full spectrum of mood disorders. So you could have, in my view, and we're just now moving beyond the official DSM definition. Yeah, sure, you could have cyclothymia with hypomania and mild depressions, or you could have cyclothymia with just a column B version of hypomania and mild depressions, or column A version of hypomania and mild depressions, or yeah, all of these variations are possible. Um, the the more subtle the hypomanic symptoms become, the more obvious the target is depression. But because it's cycling, this is what everybody has to try to remember. It's not as one of my mentors said, it's not treating the mood du jour, the mood of today. It's treating the cycling. Target the cycling, and you don't have to target any individual symptom. Stop the cycling, and the starting place for sure is regular pattern of sleep.
Well, excellent. And going forward to our next question, it is about sleep as well. So one of our audience members wants to know if getting the same amount of sleep, 7 to 8 hours, if that matters, if it's at a different time each night.
I would be very interested to know where that question comes from. Because, for example, if it's someone who is doing shift work, um, you're kind of stuck. And if you want to keep that job, and sometimes those jobs pay better, and there are reasons to need to keep doing that, that's extremely challenging in terms of trying to do social rhythm therapy.
Mhm.
um, Nearly impossible, but I think with some really working at it, you could probably figure out a way to do that. And that would include using amber lenses to block light when it should be dark, according to the physiologic schedule. Um, but but the more fundamental question is, does the hour of sleep, the onset, putting in bed, and the offset, getting out of bed. Um, Again, I'm emphasizing those because those are the ones you can control. You can't control the sleep itself. Um, does it matter if those getting in bed hours and getting out of bed hours are at the same time every night, or can they change? Uh, Same time. The idea is to teach your body by doing those behaviors. This is where the clock, it's like setting your clock. This is time. This is the 0 hour. This is the 0800 hour. And because they're at the same day time every day, that's how you set the clock. So yeah, it has to be at the same time. If you're moving it, your clock will be chasing, trying to figure out, well, where are we? And that weakens the strength of the clock. Just a brief, longer answer here. People fall asleep for two reasons. Because their circadian rhythm says it's time to fall asleep, and because it's been a long time since the last time they were asleep, the so-called sleep deficit curve, which is gradually going up. When your sleep deficit curve matches up with your circadian rhythm curve that says time to go to sleep, that's when you can fall asleep. So one of the ways to have more success at sleeping and less insomnia is to have a stronger circadian rhythm. And the way you strengthen it is by having regular bedtime and rise time to strengthen your idea, your clock's idea. What time is it actually? And last thought on that, very brief. We used to get this from the sun, right? The sun would tell you what time it is. In our modern world, we mess that all up. If you had the sun to tell you, you wouldn't need the regular bedtime and rise time so much as we need them nowadays.
Mhm. And so our next question is if there are any medications that can help with executive functions, more specifically to improve focus.
Uh, you can probably tell my bias already. Well, of course there are. We know of them. There are numerous medications. They're the ones that we use to treat so-called attention deficit disorder. I'm one of those people that it really has difficulty swallowing the idea of attention deficit disorder. I'll admit to that. And I try to keep that in mind when I'm working, when I used to, I'm retired now from it. But when I was working with patients, I tried to keep my own bias in mind so as to not be unfair in the presentation of options. But my bias is attention deficit is what you get in when you live as a normal human being in this modern society that demands these things of you that your physiology was not prepared to deliver. Um, Now, there are exceptions, many, many exceptions, and some people are so far out on the distribution of attention that uh, okay, there are some people who warrant maybe even a diagnosis, attention deficit disorder. Um, Having confessed that bias, then my bias is then, oh, for sure, let's make sure that bipolarity and cycling is not driving the attention problem. Step one. If there's no longer any cycling and attention is still a problem, and the reason it's a problem is because a given person with this experience couldn't really function, couldn't do important daily things in the life that they'd carved out for themselves and chose to have and chose to keep, then I'd think about maybe looking at a stimulant approach like modafinil, one of the, I think, a little bit more physiologically targeted. It's not an amphetamine. Um, I might think about having a discussion about that with my client patient. Remember, this is the life that you chose, not the life that's necessarily being given to you that your physiology doesn't match up with. You're trying to be something that demands rigorous attention, like a um, writer or a composer, and do it like on some kind of time schedule. So you're not free to be creative. You have to be producing, and you really need to focus your attention and crank it out. I'm not talking about something like a video game programmer or writer where bursts of absolute intense focus are really great. That's fine. That doesn't need a medication to drive it. The screen and the challenge can drive that. So again, you can see me leaning over backwards to avoid getting into a stimulant medication approach. But I would, when mood is stable, consider it, and then I'd be watching to make sure that it doesn't destabilize mood. The literature says that doesn't happen very much. I'm not so sure, uh, but we can just find out. We'll just watch closely.
Mhm. Yeah, so moving forward to the next question, can antipsychotics be useful for treating negative hypomanic symptoms?
Can antipsychotics be useful for treating negative hypomanic symptoms? For sure, because the negative hypomanic symptoms are manic symptoms. They're the agitation, irritability, anxiety, attention problems mixed in with depression. Those are manic symptoms. And so an anti-manic agent, like an atypical antipsychotic, yes, in fact, nearly all of them would be useful in that respect. Some of them have more antidepressant clout than others. And some of them with the most of that antidepressant cloud can actually become mood destabilizers. Risperidone, I think, was where we started to figure this out, but there are case reports of inducing hypomania and mania with nearly all of the atypicals, including lurasidone, the one that just recently went generic and might now start to become part of the conversation. Um, again, I'd be using them with caution, because nearly all of them, even lurasidone, can cause weight gain. So I'd be using them with caution for that reason as well. And so therefore maybe using them temporarily. And again, I'd start by going, what's happening with sleep? Um, how dark is your bedroom? Do you need a dawn simulator to help set your rise time, set your clock to a rise time?
Mhm. Yeah, so our next question reads, what's the most subtle presentation of hypomania that you would still consider pathological? And how do you recognize them in your patients?
Thank you for that question. Um, I think you're inviting me to remind everyone that at its most subtle end of that wedge, it's not pathology at all. Um, and in fact, when does this become pathological? Well, pathology, that's an awful term. I mean, it sounds bad anyway. Why don't we reserve that for um, warrants treatment? So if it's not to reach to the point where treatment is necessary, this is not pathology in my view, at least if neither the person with the symptoms nor their significant others or maybe their employer, if no one thinks that these symptoms are a problem, they're not even really symptoms, it's just life, then it's not pathology. When it's interfering with function and when it reaches the point of warranting treatment, then okay, that's the point at which I would say, okay, these are, oh, we could call it pathology. But when it's much more subtle, far, far below that threshold, it can tell us what treatments are more likely to work, or at least it can tell you that an antidepressant approach to depression is maybe not such a good idea. It carries more risk than when those symptoms are not there. So looking for that subtle hypomania is, I don't look for it to see if it warrants treatment or it interferes with function. At subtle levels, it doesn't. Um, but I look for it to see whether or not an antidepressant might be a bad idea. And if you look at that depressioneducation.org site, that's how it's all structured. Someone comes in with depression, what do you need to know before treatment? You need to find out not only what the pros and cons of various antidepressants are, but you also need to figure out, well, is there any of this subtle stuff going on? Because that shifts the way you think about what your treatment options are in essence versus lamotrigine, say. Thank you for that question.
Yeah, and so we're gonna have time for about two more questions here. And our next question is, there are any suggestions to help limit stress, aside from mindfulness and meditation, which is what this person enjoys to practice?
Thank you. I'm going to breathe for a moment myself. A good reminder. Um, One of my colleagues, I mentioned this film, this Brainstorm, the film. We're making a documentary, hopefully for public broadcasting and elsewhere, about the bipolar spectrum. My colleague driving that effort is Sarah Schley. She wrote a book called Brainstorm, which is just a beautiful description of bipolar II, and beautiful in the sense of it's so well described. It's fascinating, and it's just a very compelling read. So I'm obviously plugging Sarah's book. When I read it, I read the preprint manuscript. I read nearly the whole thing standing in one place. It was just so gripping. Um, Her memoir of her experience with bipolar II, which goes from horrible, nearly lethal, to fully functioning, no compromise, just a beautiful example of how well treatment can work. Um, so, um, Jake, how did I get there? We were looking at, um, sorry, this is probably an age thing. Could be an age thing. The
It's all
person's question
good.
was,
We're just talking about tips to manage stress
thank
outside of
you.
mindfulness and meditation.
Thank you. So Sarah Schley's version of this, she calls PECS. And I'll confess I haven't mastered her acronym, but it stands for doing something physical. So physical activity, because it helps your body rev up. When you come out of that revved up state, you are in a more physiologically relaxed state. So going up in order to come way down. I think that's an important component, whether that's a walking meditation, for example. So being physically active. Um, and she has several other ingredients in her PECS program, but I mention it because um, community, having a supportive group of people is part of that program, and spiritual, in whatever way in which you want to bring that in, those are other ingredients in her approach to this. So in part, I'm deferring to Sarah's lived experience as a way to answer that question. Um, I've been super fortunate not to have to become a master of stress reduction, um, for having had a very fortunate life. So I don't regard myself as an expert there, but as you know, there are many people out there with many ideas about that. So I'll, that's a long answer to say I'm not an expert on that.
Yeah, it's a great answer, nonetheless. And I do want to let our audience know that we have a webinar with Sarah and Dr. Phelps from 2023. If you would like to go view that on our website. And we're going to move into our last question of the day, which is, can bipolar make you forgetful, and other ways to combat this?
Yeah, it's a scary thought, isn't it? Like, what is this thing doing to my brain? Why am I forgetful? Is it because of my bipolar component in the way that my brain operates? Well, certainly when attention is compromised, memory will be compromised. Like, where did I put my keys? Well, if your attention was someplace else when you put your keys down, that's going to be causing problems in terms of finding those keys later. So, for sure, um, hypomanic phase, including dysphoric hypomania, could be associated with forgetfulness for sure. Is there a long-term process underway in which forgetfulness becomes more prominent? Like there I was having a forgetful moment a minute ago, trying to remember how did we get to that question? Um, so that's an aging phenomenon, and a scary one. And that's the reason why I'm taking 150 milligrams of lithium, because I think the literature is pretty convincing that I'm just trying to put some lithium in my water supply, so to speak, as some people have naturally in the place where they live. So yeah, so there's a long-term potential for becoming more forgetful, and trying to differentiate that from bipolar symptoms and the forgetfulness associated with symptoms. And from, as the questioner likely knows, there are data suggesting that in bipolar 1, fully psychotic manic episodes can have physiologic effects on the brain that we might expect could manifest later in terms of forgetfulness. And how applicable is that in hypomania and more subtle versions of bipolar disorder? We have no data on that at all. So I think sufficient to do one's stress reduction practices and one's symptoms really well controlled, stop the cycling, um, and focus on quality of life. Um, I guess beyond that, I'm really not adding much beyond what you already know. So thank you for the question.
Well, so that'll be all the time that we have today. I want to thank everyone in attendance, and I would like to let you know that this presentation will be available on ibpf.org and on our YouTube channel. And as always, we love to hear feedback, so please email info@ibpf.org if you have any. And we would like to send our deepest thank you to Dr. James Phelps for joining us today. And Dr. Phelps, do you have any closing comments?
Uh, Thank you to attendees for coming today. I appreciate the opportunity to talk with you. Thank you, Jake, for hosting us. And thank you to the International Bipolar Foundation for the very important work, this and many other things that IBF is doing. And I wish everyone very good luck with their treatment efforts, and pleasant rest of your day.
Mhm. Well, thank you so much for those kind words. Yeah, everyone have a lovely rest of your day. Thank you.